Frotteuristic disorder represents a significant paraphilic condition characterized by recurrent, intense sexual arousal from touching or rubbing against nonconsenting individuals in crowded public settings. According to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, this disorder requires that fantasies, urges, or behaviors persist for at least 6 months and either cause clinically significant distress or functional impairment, or the individual has acted on these urges with unwilling victims. This condition constitutes a serious violation of personal boundaries and represents a form of sexual assault requiring comprehensive clinical intervention and careful legal consideration. The clinical understanding of frotteuristic disorder has evolved considerably throughout psychiatric history. Early psychoanalytic theories interpreted this behavior as manifestations of unresolved psychosexual conflicts, particularly relating to castration anxiety or developmental arrests at specific stages. Contemporary psychiatric approaches have embraced more sophisticated biopsychosocial models that recognize the complex interplay between neurobiological predispositions, psychological vulnerabilities, developmental experiences, social learning processes, and environmental factors that contribute to the emergence and persistence of frotteuristic behaviors. Individuals with frotteuristic disorder typically experience sexual excitement through secretive physical contact with unsuspecting victims in densely populated environments. Common locations include public transportation systems, elevators, shopping centers, concerts, sporting events, and other venues where physical contact might appear accidental or go unnoticed. The behavior often involves touching intimate areas such as buttocks, breasts, or genitals, or rubbing one's genitals against another person's body. The arousal derives not only from tactile stimulation but also from the secretive nature of the act, the power dynamic involved, and the violation of victim autonomy. The onset of frotteuristic disorder typically occurs during adolescence or early adulthood, with many individuals reporting initial urges during teenage years. Research demonstrates a pronounced gender disparity, with males comprising approximately 95% of diagnosed cases. Female cases exist but may be underreported due to different behavioral manifestations and societal detection patterns. The condition often follows a chronic course with episodic intensification during periods of psychological stress, interpersonal difficulties, social isolation, or significant life transitions. Neurobiological research has begun illuminating potential brain mechanisms underlying frotteuristic disorder. Studies suggest dysregulation in neurotransmitter systems, particularly serotonin, dopamine, and norepinephrine pathways crucial for impulse control, reward processing, and social behavior regulation. Neuroimaging investigations have identified structural and functional differences in brain regions associated with executive function, impulse control, and sexual arousal, including the prefrontal cortex, anterior cingulate cortex, and limbic structures. However, establishing definitive causal relationships requires additional longitudinal research. The psychological profile of individuals with frotteuristic disorder reveals consistent patterns informing clinical understanding. Many exhibit social anxiety, interpersonal difficulties, challenges with intimate relationship formation, and problems recognizing appropriate boundaries. Comorbid conditions frequently include depression, anxiety disorders, attention deficit hyperactivity disorder, and other impulse control disorders. Research suggests frotteuristic behavior often serves as maladaptive coping for underlying emotional distress, including feelings of inadequacy, social rejection, loneliness, or powerlessness. The temporary excitement provides momentary relief from chronic psychological distress. Clinical assessment requires specialized expertise from mental health professionals trained in paraphilic disorders. The diagnostic process involves comprehensive interviews exploring sexual history, behavioral patterns, urge frequency and intensity, functional impact, and associated psychological factors. Clinicians must differentiate between true frotteuristic disorder and other conditions involving inappropriate touching, including substance-induced behaviors, manic episodes, intellectual disabilities, autism spectrum disorders, or personality disorders. Assessment may include structured interviews, psychological testing, and physiological measures evaluating arousal patterns. The secretive nature of frotteuristic behavior presents unique challenges for assessment, treatment engagement, and outcome measurement. Many individuals experience significant shame, guilt, and fear of legal consequences, making voluntary disclosure unlikely. Some only receive clinical attention following arrest, victim complaints, or authority confrontation. This reluctance to seek proactive help results in delayed intervention, continued victimization, and behavioral escalation. Building therapeutic rapport while maintaining appropriate confidentiality becomes crucial for effective treatment engagement. Evidence-based treatment approaches emphasize comprehensive psychological interventions targeting both symptomatic behaviors and underlying factors. Cognitive behavioral therapy serves as the cornerstone, incorporating multiple therapeutic components. Cognitive restructuring addresses distorted thought patterns and beliefs justifying frotteuristic behavior. Behavioral interventions focus on urge management, stimulus control, and alternative coping strategy development. Relapse prevention techniques help identify high-risk situations, develop effective coping mechanisms, and maintain long-term treatment gains. Acceptance and commitment therapy demonstrates significant effectiveness by helping individuals develop psychological flexibility and values-based behavior patterns. This approach emphasizes mindfulness techniques, acceptance of unwanted urges without behavioral response, and commitment to behaviors respecting others. The therapy focuses on developing meaningful life goals, healthy relationships, and sustainable fulfillment sources, replacing temporary satisfaction from frotteuristic behaviors. Mindfulness practices help individuals observe urges without automatic responses. Social skills training represents an essential treatment component addressing communication skills, social cue recognition, empathy development, and healthy relationship establishment. Many individuals with Frotteuristic disorder struggle with appropriate social interaction and boundary recognition. Training programs systematically address these deficits, helping reduce social isolation and interpersonal difficulties, contributing to problematic behaviors while providing alternative means of social connection and intimacy. Group therapy provides valuable peer support, accountability, and social learning opportunities. Carefully facilitated groups allow participants to share experiences, learn from successful peers, and develop supportive networks. Group interventions often focus on developing victim empathy, understanding behavioral impact on others, and practicing appropriate social skills. However, expert facilitation prevents inadvertent reinforcement of inappropriate behaviors or problematic strategy sharing. Pharmacological interventions may be considered for individuals with severe symptoms, high sexual preoccupation levels, or those struggling with urge control despite intensive psychological treatment. Selective serotonin reuptake inhibitors can reduce obsessive thoughts, compulsive behaviors, and sexual preoccupation related to frotteurism. Mood stabilizers may be prescribed for comorbid bipolar disorder. In severe cases, anti-androgen medications reducing testosterone levels may decrease overall sexual drive, though requiring careful medical monitoring due to significant potential side effects. Legal implications are substantial and complex, as frotteuristic behavior constitutes sexual assault, battery, or harassment in most jurisdictions. Individuals may face criminal charges, civil liability, mandatory sex offender registration, and various restrictions significantly impacting employment, housing, and social opportunities. Legal system responses vary considerably, with some emphasizing punishment while others focus on treatment and rehabilitation through specialized court programs or mandated therapy. Cultural considerations play crucial roles in understanding, assessing, and treating frotteuristic disorder effectively. Different cultures maintain varying norms regarding personal space, physical contact, and gender interactions, influencing both behavioral manifestation and societal responses. Treatment programs must demonstrate cultural sensitivity when developing intervention strategies, assessing progress, and working with diverse populations. Prevention efforts emphasize early identification, intervention, and education targeting at-risk populations. School-based programs promoting boundary respect, consent education, and appropriate social interaction provide protective factors against paraphilic disorder development. Community education raises awareness about frotteuristic behavior seriousness and encourages incident reporting. Early intervention programs for adolescents exhibiting concerning behaviors prevent escalation to serious offenses. Contemporary research continues expanding understanding through multiple approaches. Virtual reality therapy explores innovative tools for practicing appropriate social interactions, developing victim empathy, and rehearsing coping strategies in simulated environments. Ecological momentary assessment using smartphone technology provides real-time data about situational triggers and behavioral patterns. Genetic studies investigate hereditary factors, while longitudinal research examines treatment outcomes and recidivism patterns. The disorder's impact extends beyond affected individuals, significantly affecting victims, families, and communities. Victims often experience lasting psychological effects including anxiety, hypervigilance, avoidance behaviors, and reduced public space quality of life. Family members struggle with shame, confusion, and concern about behavioral consequences. Communities bear increased security costs and reduced public safety perceptions. Future directions emphasize comprehensive, evidence-based treatment approaches addressing both frotteuristic behaviors and underlying psychological, social, and neurobiological factors. Success requires collaboration between mental health professionals, legal systems, educational institutions, and communities, creating effective prevention and intervention strategies. The ultimate goal remains reducing harmful behavior, protecting potential victims, and helping individuals develop healthy relationship patterns while managing sexual urges within legal and ethical boundaries.